My name is Michele Maffezzoli and I am an oncology fellow from the University Hospital of Parma. The title of my presentation is External Validation of the Grade, Age, Nodes and Tumor Grand Score for patients with surgically treated papillary renal cell carcinoma. So the problem is that prognostic models for renal cell carcinoma are still lacking, but they are important in clinical practice because they can individualize follow-up for patients and they can help us to select those patients who may benefit from an adjuvant treatment. But for surgically treated papillary renal cell carcinoma, prognostication could be challenging for two reasons. One, existing prognostic models are derived largely from studies including patients with clear cell histology, and the second, the relative infrequency of papillary histology can complicate the creation of a specific risk stratification tool. The grand score is one of the models suggested by international guidelines to guide the prognosis of resected pRCC, and the aim of our study was to validate the grand score in a large cohort of patients with resected pRCC and to explore the accuracy in predicting cancer-specific survival. So we used retrospective data, clinical and pathological data collected by VENUSS et al. From patients who underwent partial and radical nephrectomy between 1924 and 2015 in different centers worldwide, and we used those data to calculate the grand score. So according to the grand score, each patient were given 1 point for one risk factor, which was age major than 60, tumor grade major than 2, pathological T-stage major than 3A, and nodal involvement. And then patients were stratified into 3 risk groups. We used this data to calculate cancer-specific survival, and we assessed the performance of the model with the C-index. And then, since the proportional hazard assumption was violated, we preferred to measure the restricted mean survival time up to 120 months. The results are really interesting. For us, cancer-specific survival at 60 months and median cancer-specific survival was significantly different between each grant groups. A total of 1942 patients were included in the analysis, so this was a large cohort of patients, and the C-index of the model was 0.732, which is consistent with other models suggested by guidelines, and the restricted mean survival time was also significantly different between groups. So what are the conclusions of our study? The grand score effectively stratified patients into 3 risk groups and is able to accurately predict the cancer-specific survival, similar to other prognostic models suggested by guidelines like the VENUSS or the Leibovich score. And we think that this score could be an additional prognostic tool, a reliable prognostic tool combining easiness of use and accuracy for daily clinical practice. Regarding future direction, we think that prognostic models should be prospectively validated and should incorporate genetic and molecular information. Maybe artificial intelligence or machine learning can outperform in the future traditional prognostic score. But while looking at this future, we should keep in mind one thing, which is adding variables to this prognostic model could increase the accuracy, but could also increase the complexity, and this could limit the potential applicability of our models into clinical practice. So grand score is easy to use and accurate, and this balance between easiness of use and accuracy is important for these models to be effectively applied in clinical setting. That's all. Thank you.